project to learn more about what is it like to be in the healthcare and relate that to wellness. I hope it's going, but if you don't mind. In general, for the headache specialist, it doesn't take more than a few minutes to get to a diagnosis of migraine, but we do a thorough history and examination for all of our patients. Most of the time, we end up ruling out red flags for secondary headache conditions and diagnose a patient with migraine, which is a primary headache disorder for which we don't have a cause. But we do know that genetics are important in these conditions. From the detailed history that I was mentioning to you, we do get a good sense about the burden of the migraine in terms of attack frequency and other conditions. But keeping a headache diary online or on paper can go a long way teaching us as a patients and the providers how can we manage that condition a little bit better, and can be a very simple one. I won't talk too much about the triggers, which I think they are, for the most part, overrated and very variable in between patients, in between attacks in the same particular patients. But I would say that if somebody identifies a consistent pattern where one factor is followed by the headache or a migraine attack, it makes sense to avoid that. But otherwise, a blanket elimination of triggers is not something that I generally recommend. Next slide, please. This is just mentioning a little bit along the same lines that Lindsay was talking about. Turns out that during a migraine attack, what is the most disabling seems not to be the pain itself, but the cognitive dysfunction. Next. You're working against each other. The cognitive dysfunction, which may be brain fog or difficulty thinking. And because of that, many patients don't engage in mental effort, being afraid that it's going to hurt. Yes, it can hurt. And Lindsay was mentioning next, please. Lindsay was mentioning about kinesiophobia, which is fear of exerting yourself, that's going to make your head hurt. In these conditions, yes, avoiding that can make you feel better in the moment during that attack, but if the attacks are frequent, that may contribute to the disability. Next, please. And there are many conditions that are associated with migraine. And in turn, if you address those conditions, make that better, the migraine is probably going to get better. One important thing is the rebound headache. When happens when the patients have more frequent headaches, take more and more medication, and now they have more headaches. If I have time, today we can talk more about ways to address that, because there are ways. Inflammation in the body, and there are different conditions that can be associated with this, make the migraine worse, including obesity. It's considered for some part an inflammatory condition. Other pain happened a lot in patients with migraine, and Dr. Doe was mentioning those. By the way, I feel bad being the only person standing in front of you not having migraine, but I sympathize with all of them, sympathize with all of you, and try to bring a little contribution. Low back pain, belly pain, pelvic pain. So the closer to the head the pain is, it's probably the worst in terms of migraine. And there is, for example, a direct relationship between headache and neck pain, which has its own physiological reasoning. Anxiety and depression as most common mood disorders that we see in patients with pain condition, including migraine, generally are mild or moderate, but identifying and treating those early, non-pharmacologically, with all the resources that were suggested to you, will help for headache management. Last but not the least, in this incomplete list, I would mention the sleep conditions that may contribute to making the migraine more difficult to treat. That can be insomnia, long-lasting, maybe rooted in childhood, and the snoring, sleep apnea. Next, please. Moving on to talk about a little bit of some strategies how to address this. mind and body is something that we have suggested as a big fundament in addressing your migraine disease, but the doctors or providers can come up with abortive or preventive interventions on top of that fundament. Next, please. And we know, I don't, but I know from you that migraine attacks can be very severe, and the patients would do everything to get rid of that pain. Provider to understand that and try to come up with ways to help you in the moment, to give you tools to get rid of that bad attack. Next, please. I'm not sure how well this projects and how well do you see it there, but in general, migraine attack, it's influenced by what's the baseline excitability of the brain. And on the other side, what's the threshold for the brain to become activated? So what we do in terms of addressing all these kind of conditions is to try to lower that baseline excitability or to raise that threshold. And there are medications and different interventions that can do this. And next, please. It's important to take care of your body. And this is a paper that I frequently cite and other people do too, talking about the fact that if you have regular patterns of meals, exercise, daily exercise, and sleep, you're more likely to stay in the blue zone here, which is episodic headache. They are less frequent. If you do more randomly those kind of three activities, you're more likely to be in the pattern of frequent chronic headache, the red bars. Next, please. Thank you. I know the sophisticated approaches that Dr. Doe was mentioning are coming, and I encourage you to read more and search more about those. But currently, I think the cognitive behavioral therapy, relaxation training, and biofeedback are probably the most common biobehavioral interventions that have been shown to be successful in the management of patients with migraine. Probably even more when they are combined with pharmacological preventive therapies. Thank you. Next. Building on more a little bit on that side, I would say that core health measures are important, including adequate nutrition and hydration. Moving a little bit more today than yesterday, building up, try to avoid setbacks can go a long way, and that was mentioned before. There are different ways in which you can become aware of what you're feeling in the morning, in the moment, not judgmental. And that is not my specialty, but I encourage you to speak with a specialist. May or may not have time to talk more about connecting with people, but the fact that you are here is so important. The fact that online people are attending, are interested in learn more about this, I think is so important. Advocacy, and we're going to talk more about this, and cultivating relationship can help actually manage your conditions. Migraine is a treatable condition, and you can have ways you can get better. And I know it's easier for me to say than done. As Lindsay was mentioning too, the growth mindset is important to build up on or cultivate or appreciate successes, try to get back from temporary setbacks, accept that you have this disease and commit to manage it is something that we are going to continue to encourage. Next, please. And the way to address this, we're going to say one more time because we really think it's important, is advocacy. And Dr. Young, it's one of the most fearless advocates, which has published extensively on this, and he continues to advocate for on your behalf, on our behalf, because we are all in this together. Migraine person with migraine can suffer multiple microaggressions, both at work, at school, in the families, because this is an invisible disease. in terms of society approach to this, there are a lot of things that can be done to educate a lot of people, because structurally, these laws and policies that are in place are not very supportive. And based on what I've just said, personally, you can internalize the stigma. And that comes with a host of different types of problems, including low self-esteem, more depression, more anxiety, more pain. And eventually that can lead to give you up sometimes, associated with concealment, presentees, which is you're there, but you're not really functioning. And eventually, potentially withdrawing from the society, which we really don't want to happen. Next, please. How do we advocate? I'm not here to speak for Dr. Young. I cannot speak like Dr. Young or Shirley, but I was just mentioning that telling the story is important. And you have one more chance to tell your story today. And with telling the story very briefly, because I've been through this in different situations, it's important the language that you use. And CHAMP organization has a very nice way in which they show recommendation how to use that language. For example, say migraine as a disease, not migraines, migraine attacks, say, for example, person or individual with migraine, not migraine sufferer, not migrainer, that recommendation. If you use image to show other people what migraine is like, try to make it diverse, because the people with migraine are from different backgrounds. Try to show the diversity of migraine itself, because there are many symptoms. It's not just the headache. And try to not depict the migraine as a glamorous condition or mild condition, because it's not. We know it's not. It's important to come up and being an upstander for yourself and for other patients with your conditions. The doctors are really happy to help you get accommodations, and I encourage you to ask for those if they are not offered to you. So in general, supporting others, sharing your conditions is going to come back and help you. And the only way to make things better is to get involved and to have other people involved, and that's going to drive change. Next, please. Just trying to get in a little bit more details about how to address acute treatment and preventive treatment of migraine. I would say it's a good idea to strategize. And strategizing means being prepared with different types of drug according to different types of attacks that you're having. With the caveats that I mentioned before about the triggers, if you are able to identify reliably something like that and address it, that can be good acutely. It's important to treat early. The danger with that, it might be that you're taking too many medications and can lead to rebound. Stomach empties a little slower during a migraine attack. So bypassing the stomach, it's a good idea to have the relief that you want from the medications that you take. And with that, injectable options like triptans, it's a good idea. Even in this day and age, laying down in the dark, quiet room is probably one of the best interventions for migraine attacks. And if you are able to, if you're not in big crisis like it was mentioned before, different biobehavioral intervention in the moment can potentially help. Again, I don't want to tell what I'm not supposed to tell because you are the specialist. And you need to most of the time, acute medications are necessary. They have a good place in that. We try to prepare with the first line medication, with the rescue medications, backup medications, and consider comorbidities when you make your toolbox to try to get rid of a migraine attack or make it portable, and consider devices for that. Thank you. Next. This is a list of most commonly used abortive medications. Some of those and a lot of time Patients with migraine do use non-specific medications like non-steroidals, steroids sometimes, anti-nausea medications, some that are maybe less desirable opioids, but they have their own place sometimes, and a lot of miscellaneous. I'm happy, we are happy as headache specialists for the patients that the specific group of abortive interventions, it's growing. And that includes triptans, which have been around for decades. So with ergotamine, dihydroergotamine derivatives. And in the last few years, we have this very, very exciting development of CGRP-directed drugs. I'm talking about GPANs, and DTANs is another class derived from the triptans that is available. Next, please. Yeah, sorry about that. Yes. Can you go back one slide? Those are so that can make somebody happy, you know, if you take all these drugs. And it's I mean, it's a good idea to be happy and not sad, not angry, because the head hurts, you know. But we have to balance a little bit all these approaches. Yes, we do drugs to patients. Next, please. Yeah, I'll get back to those. But before that, I want to say that to emphasize again the importance of having a strategy for migraine attack, because during your migraine attack, oftentimes there is concentration difficulties, and you may not find what drugs, you may not remember what the doctors told you. I need to take the drug as a first line, as a backup, as a rescue. But it's important to have that plan. And when you decide about what you want to use, to look into your attack profile, and the calendar may help in that, in associated symptoms and the level of disability. And I'm going to emphasize one more time, treating early is important. Next, please. It's a big table with a lot of drugs, and you know, four columns. These are most commonly used. We have the triptans, which have been around since early 90s. There are 7 of them, all come in tablets, a couple of them in nasal spray. One particularly is batriptan. Okay, excuse me. It's injectable. And there are different other differences. There are differences among the triptans. I would say if one doesn't work, you can try another one. But if you have tried 3 and they have not helped, the 4th one is probably unlikely to help. And then we have dihydroergotamine. Ergotamine tablets are not recommended, but dihydroergotamine nasal spray and injectable is a very good tool. Lasmiditan is the only D10 that we have available. I would suggest that's an option for people that cannot tolerate or have contraindication to the triptans category. GPANs, we have 3 of them. One, which is the last came on the market, Zavspread, is the only nasal spray. The other 2 are tablets. And I cannot say one works necessarily better than the other, but both have not the side effects of the triptans, not the contraindication of the triptans, and they are good options. Non-steroidals are very commonly used, especially the over-the-counter one, ibuprofen and naproxen. There are many others that can be used based on the doctors and patient preferences. And we do have 2 combos of non-steroidal and triptan, the older Traximed and the newer one, Simbravo. Next, please. Oh, no, back. And the column of anti-nausea medications, the dopamine blockers. There are many of them. They have their role into the migraine attack. They are sedating though, so I keep that in mind. And with all these 4 columns, they can be combined in different types of cocktails. So many patients use that term. We don't necessarily, but it is kind of cocktail that you can use. I would say don't combine 2 drugs from the same column for the same attack within the same day, especially for the triptans. But you can buy the other ones. Thank you. Next. Don't take 2 from one column. Just 1 from each column that you can combine, and you can make your own combination. Triptan plus a non-steroidal in the same pill or in 2 different pills, for example. Add an anti-nausea, that can help you actually absorb the other medications better. So these kind of combinations. Yes, yes. There are recent abortive interventions. I'm going to need a little bit more than that, if that's okay. One of them, which came on in June or May, is Bravo, a combination of a non-steroidal meloxicam and rizatriptan. It's a very good option for us to try, and the patients are willing willing to have more resources. And then we have dihydroergotamine, 3 of them formulations which are newer and as a nasal spray, which improves the absorption, and one of them is the auto-injector. Next one, please. I want to touch on the problem, which is the rebound headache. Some of the medications which are bad, called bad, because they do lead to rebound more commonly, and that's difficult to treat. That's opioids and butalbital containing medications. Triptans, Excedrin, other non-steroidals, anything can cause rebound headache, but they are probably easier to deal with. Next, please. Yes. Yes. Slide. Yes. Yeah, rizatriptan is preferred for many reasons, because it's specific for migraine, it works, but if anything that you use too frequently can lead to rebound headache. Opioids and butalbital, you need less days per month of using them to cause rebound headache. For rizatriptan, for example, the number may be 10 days a month. If you use that consistently, that can lead to rebound headache. There are different layers that I can address your questions. So one layer is this over-the-counter are available, you take it, but generally they are not as effective. If you have a mild, moderate headache, that may do it. But it's moderate or severe headache, the triptans are recommended, for example. I'm going to get back to you in the Q&A section. So it's preferable always to stay home and take medications and treat your attacks. But it is not always possible because of the severity and duration of the migraine attack. And we have options to address that, either by admitting the patient for an infusion or doing an infusion in outpatient setting. And there are advantages and disadvantages with admission and an infusion. I'm just gonna, just for the interest of time, move forward one more time, if you don't mind advancing. The ED question is important. We generally want to avoid going to the emergency room as a migraine patient for multiple reasons, but sometimes if there is new neurological symptoms associated with your headache, if you cannot keep the fluids and food down, it's reasonable to go there and check that condition. Next, please. This is a study, and it's complicated. I'll try to make it simple because I want to make the point that the fact that if you have frequent headaches, that may predict more frequent headaches in the future. And they look at a population of patients that had a headache. Here in this particular graph at the axis level, there is the actual number of the headache that people were having at the baseline, from 2 per year to 104 days per year. And about 1 year later, they asked the patients again how many headaches days they are having. And the vast majority of patients that started with less than 104 headache days per month stayed within that limit. But some progressed as the upper curve there to have an intermediate headaches up to 179 per year, and about 3%, starting with a relatively low frequency, became chronic daily headache, more than 180 days per month, per year, meaning more often than not. The red arrow there points to the 52 headache days per year, which is about 1 per week. Those that had at least 1 per week of headaches were more likely to go on and develop more frequent headaches like that. And I think this is a condition or population that we need to monitor a little bit better to prevent that progression. Next, please. And then in headache clinics like ours, we see this often, that the patient gets more and more frequent headaches. And some point, what you have as first line and rescue is not helping. So we need to become more aggressive, and become more aggressive by using steroids, for example, nerve blocks, using DHE daily for a few days. Next, please. I apologize for that. Thank you. Let's move on to the important topic of preventive treatment. We think that preventive treatment is necessary when the migraine significantly interferes with the patient's daily routine despite acute treatment. If the attacks are frequent, I mentioned 1 per week, with the risk of rebound. If the headache is not that frequent, but headache is associated with symptoms like weakness on one side, hemiplegia, or stroke-like type of aura symptoms, even if the attacks are not as frequent, it's a good idea to consider a prevention. Also, if the acute medication that you have in your toolbox don't work, they are contraindicated, they have side effects or overuse, prevention is important. And again, the patient preferences, whether or not starting a preventive, it's obviously the way to go. Thank you. Next. Society came up a few years ago recently with guidelines or consensus statement about how to use treatment for migraine prevention and abortive therapies. And part of that consensus statement is ways to appreciate the success, the outcome of your intervention in terms of prevention. 50% reduction in the frequency of headache days. It's some very common measure that we employ in the practice. But besides the frequency, significant decrease in the attack duration and the severity, as well the improved response to acute treatment is a success, as well as decrease in disability of migraine, improved in functioning on important areas of life. We think that's also an important measure of the success. Health-related quality of life to improve, reduction in psychological distress for migraine. We think it's, or they think, it's important to be considered as a measure of success in the prevention. Next, please. And this year, International Headache Society put out a what they called high standards for migraine prevention. And I'm going to walk you through, and I apologize for going over, through this picture, which shows different categories of patients with migraine based on their severity. Somebody can be unfortunate enough to have it daily, 30 days per month. Other people have 20 or 15 or 8, and all these patients have a lot of sufferance from their migraine attacks. And you can have 30% to 50% with your intervention reduction in this number of headache days, which is clinically meaningful, but it's not going to get you to what they call optimal control in the left column there, and you have less than 4 headache days per month. And I think they want us to shoot a little higher, 75% reduction in the monthly migraine days, which is a good goal. Maybe not always achievable, but it's something that we really think is possible. Next, please. From the same paper, in 1 second, being on a green zone in terms of headache frequency gets you in the green zones in terms of the quality of life. Next, please. What are the preventive interventions? For many decades, we have borrowed from other specialties, anti-seizures, antidepressants, blood pressure medications that would give you that 30–50% reduction in the headache frequency. And we have, some effective representatives of all of these classes. In the last 15 years, the botulinum toxin treatment has improved the life of many patients only with chronic migraine. And since 2018, we really have this game-changing resource with monoclonal antibodies blocking this GRP protein, which activates the pathways inside the brain. First three are injectable once a month subcutaneously, and we have Vyepti, which is every 3 months infusion. In the last few years, we have 2 tablets, Nurtec and Qulipta, that can be used preventively. So that's a resource, it's expanding. And some patients don't respond, cannot tolerate, don't have access to the above medication. So there is a miscellaneous group. Next. New targets, for example, PACAP. I'm not going to say, I know what it means by letter, but I'm not going to say it today. But they are studied in clinical trials, and looking forward to the results. Botulinum toxin variants are being studied also, trying to come up with new indications for it besides the chronic migraine and actually reducing the cost. Different biobehavioral interventions, including here the different delivery of electromyogram biofeedback. It's something that is probably coming, not yet FDA approved. And I'm going to say a couple of words about CLICK, if I can go to the next step. CT132, it's one of its kind software that was developed and actually approved by FDA to be used as an adjunct in taking care of patients with migraine. So what it does for about 12 weeks, that delivers biobehavioral intervention in addition to other types of preventives, and has shown a decrease in monthly migraine days, has shown decrease in disability, improving quality of life. Has not been, to my knowledge, commercially launched yet, but this is coming, and I think it's important for all of us to get educated in this new tool. Next, please. We do have nutraceutical, what we call them, which are supplements, and you have the doses for those that are available there for patients that are interested. These are the ones for which there is a significant evidence of efficacy. I would mention that butterbur extract probably has the best evidence that it works as a migraine preventive. The problem is the impurities in making it sometimes leads to severe liver damage, even fatal liver damage. So they are not generally recommended, but if they are used, Petadolex seems to be the purest form. Next, please. And then we have FDA-cleared devices, which provide electrical or magnetic stimulations to the different parts of the nervous system. And they all work to a certain percentage. There are patients that think that this is a life changer. There are patients that say, doesn't do anything for me. There are patients that use them, incorporating into different strategies. So they are used, they are available. One problem with those is they are most of the time out-of-pocket expenses. Next, please. Green light was found to be protective for migraine. So that kind of green light environment has found to be useful. Blocking the blue portion of the light spectrum with something called FL41 tinted glasses, a couple of examples you have here, has been shown useful for the patients. Looks like none of you is wearing that kind of glasses today. So I would suggest to consider, and they can wear variants inside or outside. Next, please. In summary, migraine is a disease. You have about 40 million people in the US that have this disease. The good news is that it's treatable. If the triggers are identified reliably, which is not always the case or not often the case, addressing those is it's useful. A reasonable question to ask is, what are you doing to create a healthy lifestyle for you as something with migraine? And I'll leave that question open. And what else is going on besides the migraine in your condition? So addressing associated medical conditions is going to help with migraine control. Importantly is to address, and not because we are just part of advocacy here, but advocacy is something that we prescribe we recommend, we encourage, because it has an important contribution to your toolkit. You decide how important it is and how you address it, but it's a suggestion that we are having. And I mentioned to you in some details the abortive, acute medication, and preventive options, and there are some best practices in how to use those. I'll be happy to answer any more questions about that. Keep in mind the devices. I think it's all I have. Thank you so much for your attention. Next slide.
No, you were not on time, but because you are a fearless advocate, just like Dr. Young, we're going to keep him, right? Hopefully you learned something today. I'll come back. We actually, this has never happened. We have one question, Dr. Birlea, for you. So the question is, what about the Reed migraine procedure?
So, which procedure?
The Reed migraine.
In general, we recommend invasive interventions, which Reed migraine procedure is a stimulator that is implanted in the nerves in the back of the head, in the front of the head. I personally recommend to consider that when everything has failed. I have patients who had the procedure, but still has the same type of burden for a migraine. So in general, we recommend procedures like this to be done as part of a clinical trial and not necessarily widely.
Okay, good. Can you explain rebound headaches? What is it? Now you said that term, and we have everyone almost in the room today has never been to an education event.
The speakers here, so to help if I.
What's that? Yeah, of course. Lindsay, you want to answer that question?
No, if you want to stay here, I'll try to answer this question.
Okay, well, okay.
Clinically, people have more frequent headaches and they want to function, and they are going to take medication to try to address that attacks. If you do that frequently, and we have some numbers what frequent means for a prolonged period of time, there are changes that happens inside the brain that favor that neuroplasticity that Dr. Doe was mentioning in a negative sense. So that's a short type of answer that I can provide to that. And there are ways in which you can address that by reversing it. And there are probably better ways to prevent that. But it's still controversial. There are headache specialists that think that having frequent headaches is just having frequent headaches, and you have to take medication for those. And not necessarily it's a different type of biology that you develop a new headache on top of that, but it's your own migraine biology that has fluctuations like this. Does it make sense? Thank you so much.
Thank you. What?